So you're live, we can start now.
Can I start, sir?
Yes, sir. Yes, please go ahead.
Good morning, everyone. Myself, Dr. Arun, and welcome to the today's discussion, that is design of clinical trials. So you can see in this slide, epidemiological studies broadly divided into two categories. One is descriptive study, another one is analytical study. Descriptive study design, again two kinds, based on study of unit, that is case reports, case series, cross-sectional surveys. In these kind of study designs, study of individuals are the unit of the study. On the other hand, in ecological studies, unit of study is population. In analytical study, again divided into observational study and international study divisions. This observational study or analytical study is divided as a case control and cohort studies based on the direction of the study. The other one is interventional study or randomized control trial. We'll see all study designs in detail. First, coming to case report. As a resident or clinician, you may come across case reports in various journals. What is case report? Case report is a detailed presentation of a single case. It is beneficial when you are unfamiliar disease. In your practice, when you come across any new manifestation, any interesting finding related to your imaging or labs, that you can document and you can share with your peers. So you are sharing that knowledge when similar kind of situation, when your colleagues are facing, that might be helpful for them how to handle that unfamiliar situation. It is helpful to generate hypotheses also regarding pathophysiological mechanisms. Here you can see an example of case report. All peer-reviewed journals publish case reports in a separate section. When you are reading a case report, along with that new manifestation or new finding, you can see what is the existing literature available at that point of time. Next, coming to case series, it is step ahead than case report. In case report, we'll study in detail about single case. Whereas coming to case series, here group of patients will increase slightly. Larger groups, maybe 5, 10, like that. So what is the advantage comparatively than case report in case series is, here, because one is large number of people you are assessing, so this will be helpful to you to differentiate that the finding what you observed, is it really due to the disease or due to the chance. It will helpful to differentiate this thing. So common way of delineating the clinical picture of a disease. But in case report or case series, there is no comparison group. Next, coming to ecological study. As already mentioned, in case report, case series, study of unit is individual. But in ecological study, study of unit is group. Let me give you an example for ecological study. For example, is there a relationship between air quality index and the number of hospital admissions associated with respiratory tract infections? That you can take any region, any state, or any city, or particular place in the country. For example, you can take like different metropolitan cities, Delhi, Bangalore, Hyderabad, see air quality index and hospital admissions, whether there is a relationship. If better the air quality index, you may find result like better the air quality index, lesser the number of hospital admissions. Or on the other hand, worse the air quality index, higher the hospital admissions. So that will give you an idea in that region what is the magnitude of the problem, and at the same time it will be helpful to generate hypothesis and what can be done to mitigate that problem. So as already mentioned, this you will get a data based from the group. So you won't get the data at individual level. That is the main limitation with ecological study. coming to cross-section study, this is an important study. In cross-sectional study, you will get particular information at a specific point of time, and you will assess both exposure and outcome at same point of time in cross-sectional study. In cross-sectional study, it is observation of cross-section of a population at single point in time. Here again, same like case report and case series. Cross-section study also, study of unit is individual. You will collect the information about disease burden. That's why it is also known as prevalence studies. Recruitment of study participant can be population or population sample. Best example for this cross-section study surveys are your census. That in India we will do every 10 years once. So for example, 2011 census happened. The time they have a detailed pro forma. Based on that, they will collect the detailed information. So for example, 2011, that information was collected. And by coming to 2012 or 13, the same information may not be true. That is the limitation. But problem is when you are taking 1 billion population data, it is not possible to repeat more frequently. So in these kind of situations, cross-section study is better alternative to get the sufficient to get the data when you are doing a study in a large involving large population. And at the same time, observation for the presence, you can get one or more outcomes or one or more exposure. Use of cross-sectional surveys are, one is already told, cross-sectional surveys, otherwise called as a prevalence studies. It helps to estimate prevalence of disease or the risk factors. And problem with this study is you are doing at a particular point of time and you are assessing exposure and outcome at same time. So which one happened first, exposure or outcome? It's difficult to differentiate that. For example, patients having hypertension also having obesity. Obesity is causing hypertension or hypertension is causing obesity. We cannot differentiate. For that, you need comparator group or you need to test your hypothesis. For that, you need other type of study designs. But with cross-section surveys based on your study results, you can set your priorities and it will give fair idea about magnitude of the problem, what is the burden of the problem on society. It can be health related or non-health related. And it also helpful to generate hypothesis. And I already mentioned, you can generate hypothesis, but we cannot test your hypothesis because you need a comparator group. For that, you need different study designs. And also it will be helpful for examining trends. You got the result based on cross-sectional survey and you implemented certain necessary precautions related to that. And again, you can reassess and check whether your intervention actually working and the burden is reduced actually or not. So that in that situation also cross-sectional surveys are very helpful. Here you can see on example of cross-sectional survey which was published in 2023. That is practice patterns and management protocols in trauma across Indian settings, a nationwide cross survey. Here there are involved almost 480 odd centers in this particular cross-section survey. And what are the practice patterns currently going on nationwide? And in which areas actually we are doing better? What are the areas we can improve? That was in detail discussed in this particular survey. So already mentioned, advantages with cross-sectional surveys are fairly quick and easy to perform. These are less expensive. But limitations are you don't know the study disease etiology because you are assessing exposure and outcome at the same time. And it is not suitable for study of a rare diseases. So this is about descriptive studies. In descriptive studies, actually discussed about case report, case series, ecological and cross-section survey. Now we are moving to analytical studies. Analytical studies divide into two types, that is experimental and observational. If investigator assign exposure, then that is called experimental study. If did the investigator assign exposure, if answer is no, then it comes under observational study. Observational study, again based on comparator group presence or not, divided into two types, analytical study and descriptive study. If there is no, in whatever we read, whatever we discussed in case series, report, ecological survey, cross-section survey, there is no comparator group. That's why they comes under descriptive study. In analytical study, you will get the comparison group. And based on the study direction, that is moving from exposure to outcome or outcome to exposure. Based on that, it divided into case control or cohort study. In case control study, from this direct study of direction moves from outcome to exposure. In case of cohort study, study direction moves from exposure to outcome. Cross-section study, actually we discussed in descriptive study. If in case we have comparator group, that is called analytical cross-section survey. But again, already I discussed in cross-section survey, we are assessing both exposure and outcome same time. We cannot differentiate which one happened first in cross-sectional survey. So on other hand, in experimental study, investigator assigns exposure based on random allocation. Randomization happen means that is defined as a randomized control trial. If random allocation not happen, that is called as non-randomized control trial. First, we will discuss this analytical studies, that is case cohort and case control study in detail. Coming to cohort, this term actually from military origin. 300 to 600 men of Roman army, they called as a cohort. In epidemiological terms, cohort defined as group of people shared common characteristics. So here you have to select population of interest and population at risk, and then you have to divide as exposed and unexposed. For example, classical example here you can take smoking related to lung cancer. How many people exposed to smoking? So at the time of study, who are all exposed to smoking and non-exposed. First, you have to differentiate as a two groups you have to keep, and over period of time you have to observe them. Among exposed, how many they develop disease and remain non-disease in both groups we have to assess, and that will give you the incidence among exposed and incidence among non-exposed. Based on this, you can calculate relative risk. So type of cohort studies based on when the study actually starts. In prospective cohort study, by the time study starts, exposure and disease not yet occurred. In case of retrospective, by the time study starts, your exposure and disease already happened. In ambidextrous study, by the time study starts, only exposure happened, but disease not yet occurred. So elements of cohort study: first, selection of study population, gathering baseline information, follow and analyze your data. In cohort study, we can measure incidence, and through the incidence, we can measure relative risk. This is the 2x2 table of a cohort study. It will be looks like this. So you will divide this 2 into 2 table. On column, you can see disease, non-disease, and exposed, unexposed. Exposed total exposed is A plus B, total unexposed is C plus D. Total diseased A plus C, total non-diseased B plus D. You can based on this data, first we can calculate incidence of disease in exposed, that is A by A plus B, and incidence of disease in unexposed, that is C by C plus D. Incidence of disease in exposed upon incidence of disease in unexposed gives you the relative risk. Your relative risk, it can be 1, greater than 1, or less than 1. If relative risk is 1, that means incidence in exposed and unexposed is same. That means exposure is not associated with the disease. If greater than 1, relative risk is greater than 1, that means incidence in exposed is higher than unexposed. That means exposure is positively associated with the disease. If relative risk less than 1, incidence in exposure is lower than the unexposed group. That means exposure is negatively associated with the disease. This is how we should interpret your relative risk. So in cohort study, we can calculate incidence based on incidence, we can calculate the relative risk. What are the strengths and weaknesses of cohort study? So as already we discussed, it allows calculation of incidence. It will be helpful examining multiple outcomes for a given exposure, clarity of temporal sequence, and that means time sequence, which one happened first, exposure, that we know clearly, not like in cross-sectional study. There will be lacking the temporal sequence. Good for investigating rare exposure also. Weakness, sir, it is all these analytical studies associated with expensive and time consuming, not good for rare disease, not good for disease with a long latency. Differential loss to follow can introduce a bias. Coming to another analytical study, that is case control study. The difference between cohort and case control study is already mentioned. Study direction. In cohort study, study direction moves from exposure to outcome. In case of case control study, study direction moves from in reverse way. Already disease has occurred, and then we are assessing what are the exposure of odds. This actually first case control study is actually done by Doll and Hill. This is in 1952. They want to test association between cigarette smoking and lung cancer. So by the time they started study, already patient developed lung cancer, and they taken controls as non-cancer patients, and they have detailed questionnaire. With that, they asked the participants to know about what are the exposure odds. Based on that, we can calculate odds ratio. In case of cohort study, we can calculate incidence. In case control study, we can calculate odds ratio. So elements of case control study are again selection of cases, selection of controls, information on exposure, and analysis. So odds ratio, this is also we will get 2 by 2 table, similarly like what we got in cohort study. Here again, exposed, unexposed cases and controls. This is total number of exposed, total number of unexposed. Total number of cases are A plus C, total number of controls B plus D. Here we cannot calculate incidence. We can calculate the odds that the case was exposed. That is equal to probability that case was exposed upon probability that case was not exposed. That is equal to A by A plus C divided by C by A plus C. A plus C means total number of cases. So finally you will get A by C. On the other hand, odds that control was exposed, probability that control was exposed divided by probability that control was unexposed. That is B by B plus D divided by D by B plus D. Finally, you will get B by D. This ratio, again, if you are taking A by C whole divided by B by D, that you will get AD by BC. That is the odds ratio. Again, similarly, like relative risk, you will get either 1 greater than 1 or less than 1. How to interpret this ratio? Odds ratio, if 1, that means odds of exposure among cases and controls are same. Exposure is not associated with the disease. In case greater than 1, odds of exposure among cases are higher than compared to than controls. In case less than 1, odds of exposure among cases are lower compared to than other group. This is how we should interpret odds ratio. Again, I'm telling in cohort study, we can calculate incidence and relative risk. In case of case controls, we can calculate odds ratio. What are the strengths of case control study? This is good for rare disease and again and inexpensive because already we are starting from the disease to exposure. So patient, by the time you are starting your study, patient had disease already developed. So you can prepare a pro forma or questionnaire, and you can ask the questionnaires and what are the risk factors, what are the exposure factors which lead to the current situation. Multiple exposures or risk factors can be examined. Weakness, susceptible to recall bias, but because you are going from already disease to exposure person, they may not recall actually what based on your pro forma or questionnaire. For few questions, they may not answer correctly. Selection of an appropriate comparison group may be difficult. So this is about analytical studies. Next, we will move to experimental studies or randomized controlled studies or clinical trials. This is the main scientific advances in methods of clinical research. This is otherwise called as a methodological standard of experiments. And this is also considered as the gold standard of clinical research. What is the significance of experimental trials? This can translate results of basic scientific research into better ways to prevent, diagnose, or treat the disease. Here you can test in your intervention. It can be a new drug, new therapy, or new diagnostic pattern, anything. anything you want to test newly, this is the only study design better and gold standard. So experimental study designs are planned experiment designed to assess the efficacy of any prophylactic drug or diagnostic or therapeutic agents. Here already mentioned this type of analytical study, we will get a comparator group. Even in case control cohort studies also, you will get the comparator group. Here also you will get the comparator group. What is the difference between case control cohort is, in case control cohort, investigator is not going to assign the exposure. In case of experimental studies or RCTs, investigator is going to assign the exposure. That is the main difference between case control cohort versus experimental or randomized control studies. And this study design is prospective in nature. So this is the schematic of preventive clinical trial. So what you'll do is, first you have to select population at risk. What is the population of your interest? And it is not possible to recruit all the population at risk. So what we will do is, alternatively, we'll take a sample from the population susceptible or at risk. And then next process is, we'll go to randomization. In randomization process, people divide into two arms. One is intervention arm, another one is non-intervention arm. So then these patients will be followed up for a time period, and then again we will assess what is the percentage of acquired disease and how many remain free from the disease. So what is the randomization? So randomization is considered as a heart of the randomized control study. Randomization ensures that participants have an equal chance to be assigned to one of or two groups. In this, when your randomization is happening, participant can't decide in which group they want to go. And one group gets the most widely accepted treatment, that is considered as a standard treatment or gold standard. The other gets, along with this standard treatment or gold treatment, the new intervention being tested. Here, hypothesis is this group may get better clinical benefit compared than standard treatment. That may be true or false. That will be assessed at the end of the study. Randomization provides the best way to prove the effectiveness of a new agent or intervention by ensuring that all groups are as similar as possible, and confounding co-interventions bias in outcome ascertainment is minimized. Another important step in randomized control trial is blinding. Blinding means which arm patient is assessed in. The participant is in single intervention group or non-intervention group. If participant doesn't know about which arm they are allocated, that is called single blinding. In case participant and investigator both don't know about the information, then that is called double blinding. In case participant, investigator, and analyst don't know about this allocation, then that is called triple blinding. So blinding helps to eliminate co-intervention. Means, for example, a participant, if they come to know that intervention group, they are getting another new drug which may get better efficacy and cure, then it might change their mind and they may want to switch from one group to another group. Not only from participant level, even from treating staff, clinician, or if they know known person is there, they also can change or switch from one group to another group. That can lead to bias. So blinding can eliminate this kind of co-intervention. Another thing is where it will be helpful is biased outcome ascertainment. That means if treating staff or clinician, they come to know that intervention group, they are developing certain kind of symptoms, they may falsely report this without assessing the patient. These kind of symptoms, they can sit somewhere else and write these symptoms already they developed. That can lead to your outcome, that can affect your outcome results. That is called biased outcome ascertainment. So what are the phases in critical trials? This basically 4 phases will be there. In phase 1, endpoint is safety and acceptability. Here, a relatively small number of people they will recruit. They might be healthy volunteers. After that, they will assess the end of the result. If they poultry and more local applications. And then it will go to the phase two. Here, relatively larger will be involved. These projects they will administer and they will check for larger safety, goals, and schedule. And the early is of efficacy. If these are the process, then it will go to the third phase.
Arun, can you check your audio? Arun, Arun,
More than 1,000 people can see. At the
Arun, can you check your audio once?
surveillance, here you will get here you will get information from the community based.
Arun, continue. Arun, can you please check your audio once? Not able to hear. Not. Arun, can you hear me? What is the problem? Display అయినా చూడు డిస్కనెక్ట్ అయినా ఇయర్ ఫోన్ ఎవరో
Yes, sir.
can you hear Arun's talk?
Sorry, sir.
आपको सुनाई दे रहा है अरुण सर जो बोल रहे हैं लेक्चर?
No, no, not actually.
ऑडियो डिस्कनेक्ट हुआ ना?
डिस्कनेक्ट तो नहीं है, वो है स्क्रीन पे, बट ऑडियो नहीं आ रहा.
एक बार चेक करो. Arun, can you re-log in?
Sir, am I audible?
Yes, Arun.
Okay, sir. Thank you.
Yeah, you are audible now. Please start from the faces.
Okay, sir.
Start screen sharing.
Okay, coming to phases in clinical trials and objectives. There are mainly four phases in clinical trials. That is, first phase is endpoints of first phase is safety and acceptability. And sample size here up to 50, and they will test among upon healthy volunteers. If this phase passes and if they observe that is safe and there are no major complications, then clinical trial move to next phase, that is phase 2. In, uh, in phase 2, endpoints or objectives are long-term safety, dose and schedule, early indication of efficacy. Here, compared to the phase 1, slightly higher, a larger number of people will be recruited. And phase 3 endpoints are effectiveness. Here, compared to then phase 2, a further larger group will be recruited. That will be in thousands. Phase 4 is post-marketing surveillance, that is 1,000 and more. Here, you won't. It is not like particular clinical settings. You will get the information from the community. So, what are the advantages and disadvantages of RCTs? Advantages are the only effective method known to control selection bias, and controls confounding bias without adjustment. It facilitates effective blinding in some trials, maintains advantage of cohort studies. That means similar characteristics of people will be taken in both intervention and non-intervention group. That already we discussed about how blinding can help us to mitigate the bias risk. And disadvantages are it is always complex and expensive. Main problem is getting the consent after decide to do study. When you are going to give a new drug or new intervention, obtaining consent from the population is very difficult. From that phase to till completion of phase, it's associated with many hurdles. That's why it is more complex compared to than previous studies what we were discussing. And it lacks representativeness. Volunteers differ from population of interest, and ethical challenges are immense. And you can see here this pyramid, that hierarchy of study design. At the base comes your individual case report. Then slightly better is case series, then case control and cohort studies. These are analytical groups. From case report, case series, case control, cohort, this all comes under observational group, because here investigator is not assigning the exposure. In experimental study group, investigator assigns the exposure group. If randomization happens, that's considered as a randomized control trial. If randomization not happen, that considered as a non-randomized control trial. So obviously, randomized control trial is superior than non-randomized control trials. After that comes your meta-analysis and systematic review in this pyramid. Designs describe who, what, when, and where of the disease occurrence, and it can generate hypothesis but cannot establish causality. In analytical studies, you can test hypothesis, explore association between exposure and outcome. It provides measures of association. That is, in case of cohort you can calculate the incidence and relative risk. In case of case control, you can calculate the odds ratio. In randomized control studies, already we discussed, this is gold standard for causality, and randomization minimizes the bias and confounding. Test is best for evaluating interventions and therapies. So in this study pyramid or design, from base to apex, when you are moving, your quality of evidence will improve and risk of bias will reduce. So obviously, whatever situated in this tip has higher quality of evidence, but study design you have to choose based on your research question. For example, I shown on cross-sectional survey which was done nationwide. For that study, actually, they decided to do at in March 2022. By the end of December, results were published. If same and they collected information from 480 odd centers. If you want to do a large scale study like that, and if your study design is either analytical or randomized control study, that's just imagine that is how expensive and how time consuming. So this so a randomized control study has highest quality of evidence. You have to choose your study design based on your research question. That's our take home points. And any questions, please feel free to discuss in YouTube also. We are happy to answer. Thank you.
Thank you, Arun, for simplifying the different types of study designs. See, it's very important for all of us to have some basic idea about what kind of study design when we are interpreting a result or when we are interpreting a trial. Sometimes it can be a little confusing, but going through the basics will always help us know the whether the study has been conducted properly or not, whether the question in relevance, whether it's an intervention, whether it's a diagnostic study, or whether it's some kind of a drug, whether the way the study has been conducted, can you apply the results of the particular study to your patient is something that you finally want to know. Thank you, Arun.
Thank you, sir. Thanks for the opportunity.
Thank you, everyone, and wish you all a very, very happy Navratri. And if you have any queries or if you have any doubts, please write back to us. We will get back with the solutions at the earliest. Thank you very much.
Thank you, sir. Thank you.